focused on bringing the cutting-edge research going on all across our university into practice, into practical application, so that it has an impact on the health of Texans and the nation, for that matter. This initiative really evolved from conversations that happened between the president and the provost, largely around promotion and tenure dossiers. And what they noticed was that a critical mass of faculty were being recruited and promoted and supported who were focused on health research. And so from that observation, there was a decision to explore the idea of having an emerging research area focused on health. Today, under the leadership of Dr. Melinda Villagran, who you'll meet a little bit later, here we are. We have well over 200 faculty that are focused on health research. We have a number of undergraduate and graduate degree programs focused on health and health professions, and we have a very large research portfolio that funds the health research. So it's been an exciting time over the last few years. And now it is my great pleasure to bring to the podium to provide opening remarks the president of Texas State University, Dr. Denise Traub.
And good afternoon to each and every one of you. I'm honored to be with you here today as we kick off the third annual Health Scholars Showcase. I'm really excited about this initiative, and I'm excited about the progress that we've made over the last 3 years. I think that what you are doing is a real gift to our region and to our community. You're bringing together so many healthcare providers, industry leaders, and faculty. And you're here today to discuss smart and connected health innovation. And I want to take this opportunity to thank our keynote speaker and our panelists who are presenting this afternoon. They are true innovators and thought leaders, and we're proud to partner with the organizations that they represent. And I'm grateful that they're here today to talk about this really important subject, health innovation. As you all know, and I think you've heard me say many times, Texas State University is positioned in the heart of what has been dubbed the Texas Innovation Corridor, the 140 plus miles that stretch along I-35 from Austin or north of Austin to San Antonio. The Texas Innovation Corridor, of course, is home to rapid growth in industry, in research, in technology, and frankly, an economic opportunity. And this is one Texas State initiative that really contributes to the Texas Innovation Corridor. This initiative, from my observation, is allowing us to accelerate the impact of our research findings on patient care, patient education, and disease prevention. And I'm extremely proud of this multidisciplinary research organization that's linking faculty, students, and industry partners who have a shared interest in innovating health delivery, health assessment, and health communication. Our goal through Translational Health is to improve the health of Texans by testing and applying research findings to address critical needs, and by partnering with corporations, healthcare providers, and community nonprofit organizations, we are translating research into practice. We currently have 225 faculty who are actively engaged in health research and over 80 degree programs that include some kind of health-related instruction and research opportunity. During the poster session today, you're going to see groundbreaking research that explores the allocation of scarce medical resources, improving metabolic health, treatment for children with autism, point-of-care diagnostic solutions, and virtual reality in radiation therapy education, just to name a few of the many innovative projects that are on display out there. We also have faculty conducting applied research on communication barriers that prevent life-saving marrow donations, nutrition for breast cancer survivors, and use of mobile applications to reduce postpartum depression, and intergenerational exercise programs that improve health and vitality during aging. And that's just to name a few. And I think all of you know that about 50 miles north of here on the Round Rock campus sits a healthcare vortex, and that's becoming the center of our health professions program. The health college here, the College of Health Professions, has been our fastest growing college for about 10 years. And that's because this area wants skilled graduates who are trained to provide quality patient care. And we believe that Texas State has great capacity to do that. So I want to take this opportunity to welcome you, to thank you for being here, and I hope that this event is both compelling and fruitful. And now I'm going to turn this back over to Walt, who's going to introduce our keynote speaker. Thank you.
Thank you very much, Dr. Trout, for those opening comments, and thank you for your leadership and support of the entire research and scholarly mission here at Texas State. So now, I have the daunting task of introducing an individual that I've known for quite some time, and to condensing that introduction down into a time that doesn't use up all of her time to present, because Susan Denzer is, again, someone that I've known for almost 10 years, and it began with my affiliation with an organization called Research America, and Susan Denzer serves on the board of Research America, and so I had an opportunity to interact with Susan in that capacity. And that affiliation with Research America is really just an example of the type of organizations that Susan Denzer has been affiliated with and led over her long and distinguished career. And I would just share that she has been elected to the National Academy of Medicine. She serves on the board on population health and public health practice of the National Academies of Science, Medicine, and Engineering. Some of you might know her from hearing her on radio or seeing her on TV. She has a long and distinguished career in the media. She's a frequent speaker and commentator on radio and TV, including PBS and NPR. She's a past editor of the policy journal Health Affairs. And for 10 years, Susan was the on-air correspondent for PBS NewsHour. In 2015, she wrote and directed the PBS documentary, Reviving American Healthcare. And she is the editor and lead author of the book, Healthcare Without Walls, a roadmap for reinventing U.S. healthcare. And it's a book that's been passing around this campus for the last few weeks, and I think has really stimulated a lot of thought and reflection as we've read that. So I'm going to try to honor Susan's demand that I don't use up all her time by just finishing with saying that Susan's in a transition phase. She was in a very compelling CEO position at a nonprofit in DC, focused on healthcare innovation. She's moving about 8 blocks down DC to take over a visiting fellow position at the very distinguished Duke Margolis Center for Health Policy. Well, she will continue her efforts focused on key health policy issues. But today she's here in San Marcos, and so please join me in giving a warm Texas State welcome to Susan Denzer.
Well, thank you so much, Walt. Thank you, President Trout. It's terrific to be here with all of you this afternoon. As you heard, I've been in this field a long time. I think you used the word long about 8 times. not that I'm sensitive about this, but it is true. I've been in this field a long time, but this is my first ever visit to Texas State University, to this glorious campus, to hear about the work that so many of you are engaged in, which is so consonant with the work that I've been engaged in, including on this effort around Healthcare Without Walls. So what a sheer treat and pleasure for me to finally be drawn down here to this wonderful campus, to this innovation corridor. And I hope this is only the first of many visits that I expect to make in the future as we work together to improve the health and healthcare, not just of Texans, but frankly of all Americans. So, and all of those resident in our country. Let me specify that as well. So, let me give you a sense of the ground that I'm going to cover today in my talk. Again, it is Healthcare Without Walls. What does it mean for practice? What does it mean for education? What does it mean for the overall system? Use this one. Let's see, do I need to point this in a particular place? Okay, great. It's always the technology that trips you up, which is dangerous if you're making a presentation largely about technology. There we go. Okay, so here's the ground I'll cover. Healthcare Without Walls. What did we mean in my prior life at the Network for Excellence in Health Innovation as we came up with this concept? What the heck were we talking about? So I'll give you a sense of what our vision was as we looked into that. I'll give you some background on the initiative. I'll give you a flavor of the recommendations that came out of it, and they were lengthy, and those of you who've been good enough to read the book know that's the case. But I'll try to encapsulate those as best as possible. And then really to talk about the heart of it, what are the implications of all this for the practice of healthcare, for education of future health professionals, and frankly, re-education and training of the existing core of health professionals as well. And how do we think about aiming toward a system that would bring the benefits that we see inherent in Healthcare Without Walls and bring them to more and more Americans? So, how do we get going down this path? At Lehigh, as I have over the course of my life, I've spent a lot of time trying to wrestle with some of the bigger questions in health and healthcare. And so we went back to the drawing board at Lehigh and asked a question that frankly has probably been asked by about 20 zillion people before us, so I have no claim to novelty here. But really, if we think about it, what we have in the US, although we call it a healthcare system, it is really a sick care system, by and large. We really focus our energies on diagnosing people who are already sick, on treating people who are already sick. That is really where the bulk of our effort and our money goes. Now, we have a public health apparatus. We do care about health prevention, health promotion, but we've kind of consigned that to the public realm, and where the money is and where the activity is and the focus is largely in the sick care side. So how come? How come? Why did we go down that road? Then the other question we started to ask is, why did we end up going down the road probably 50 or 60 years ago, where once upon a time we thought of healthcare as going to people, such as it was in those days. You know, the doctor going to assist George Washington on his deathbed by applying leeches, right? That was the precursor of it. And then, of course, we had sort of what we think of as the Marcus Welby era of house calls. But then we changed, and we went to the industrial model, where we built large facilities, hospitals, academic medical centers, etc., and we expected people to come to it. Why did we do that? Number one, and why are we still doing that in an era when, first of all, we don't have to do that anymore by virtue of technology, and also very importantly, we know so much more now about what drives health status in life, which is frankly everything that's outside the healthcare system. So why do we insist on pulling people into the healthcare system once they're sick, as opposed to going out into the community to address their needs before they get sick, right? And these are kind of obvious questions that, as I say, we were only the 20 zillionth pool of people to ask. But if you think about what is necessary for innovation, you have to, I think, come back to those first principles and those initial questions to start to think about how you might do things differently. And as I say, a big motivator for us was the focus on social determinants of health, understanding that the literature has shown definitively for years that the primary drivers of health status in life lie outside the clinical care system. You could get an argument among researchers about whether 10% of your likelihood to die before your normal lifespan is related to your clinical care or not receiving clinical care. You could get a debate, is that number 10%, is that number 20%? But nobody's arguing that it's 80%, right? The 80% is in all of these other domains. It's in social and economic factors like level of education. It's to some degree in genes and biology. It's also largely a function of the clinical environment, or excuse me, the physical environment in which we live, the health behaviors that we acquire. And then of course the real magic is where all of these things overlap. So did we grow up in a lower income household living next to a toxic waste dump, and in a family where nobody ever graduated from high school, and we didn't quite make it out of high school either, you're gonna have a different lifespan than someone who is living in a very different context than that. And so capturing this reality and then thinking about the various ways in which we can intervene or could intervene to engender healthier lives for people through all of these interventions that you see on this other side of the graph. Dealing with food security issues, dealing with transportation issues, et cetera, et cetera. Again, all of those things lying outside the context of the healthcare system. Why aren't we spending more of our time focused on that? So we asked all of that, and then we asked another question, which is, there's a whole lot of healthcare that involves laying on of hands. If I get into an accident on I-35 later this afternoon, I'm going to want to be taken to a major trauma center. I'm not going to want to have a telehealth visit with a trauma surgeon, right? So there is aspects of care that is laying on of hands, but there's a whole lot of healthcare that is really about exchanges of information. And why hasn't that moved to the way we exchange more and more information generally in our society and our economy today? Which is to say, virtually or at a distance or asynchronously or however you want to phrase it. You think about it, healthcare is really stuck in this model where we don't believe that information really matters unless it's exchanged directly face to face, which is really kind of nuts in a system where we have access issues, we have capacity constraints, we have other things that really would say to you, we ought to think of a way to leap over this constraint of having everything have to be face-to-face, if it doesn't need to be, because frankly, we don't live our lives that way with almost every other aspect of information exchange. So how come, why is healthcare stuck in this older paradigm? And leaving aside all of those areas of healthcare that do involve laying on of hands, how could we think about exchanging health information differently? Another way is to phrase this as a friend of mine, Mark Fender at the University of Michigan, puts it, why are we delivering Star Wars medicine on a Flintstones delivery platform? Why, when we have so much knowledge about genetics, genomics, proteomics, and that our knowledge is really exploding in that vein, why are we delivering it on this ancient, rather creepy platform? And what we said at Mihai is, why don't we at least advance to the Jetsons? I don't know how many of you in the audience were old enough to watch this seminal cartoon show in the 1960s, but look at how the animators in 1962 thought people would be receiving healthcare in the future. Over a television screen, right? That's what they thought in 1962. And here we are today, obviously lots of telemedicine going on in distributed fashion here in the state of Texas, but not as much as we would have thought given what people were thinking back in the 1960s. So, as we said, why aren't we at least moving on to the stage of the Jetsons? And speaking of the 1960s, we know that there were telemedicine activities going on in the 1960s. This is just one example, which is a fellow who was at the Leahy Clinic in Massachusetts, moved to the Massachusetts General Hospital, set up a telemedicine capability between Boston Logan Airport and Massachusetts General Hospital so that telemedicine could be administered to travelers coming through the Boston Logan Airport. He set this up in the 1960s. You can see it was functioning on that black and white technology of the 1960s, but it was a functional system. and then it died for various reasons in the 1970s. Almost never to be heard from in Boston again, at least until very recently. So we know these things were out there all these years ago. How come they did not take off? Really became an essential question for us. And wouldn't we prefer a system of healthcare without walls to the system that we have today, which for a lot of people looks for a long time, a lot like this. Sitting in a waiting room, biding one's time, waiting to be seen physically for various conditions. And as we thought about the types of people who could benefit from a system of healthcare without walls, as those of you who read the book see, we conjured up a bunch of individual patient scenarios. So what about, and these were hypothetical, we made them entirely up, we tried to make them as realistic as possible. But what if you were a woman with mild cognitive impairment in your early 80s and you wanted to live at home independently as long as possible? And you thought, really, there ought to be a way to support me in doing that, even if I can't always remember to take my medication, and I don't always have the ability to drive myself to a physician's appointment, et cetera, et cetera. Aren't there capabilities that would give me the ability to stay at home as long as possible? Or what if I'm a low-income pregnant woman? I'm going to have difficulty getting to a doctor's appointment anytime, but when I do, I'm going to have to take a day off from work because I work in a low-wage job where nobody gives me sick leave or medical leave. But I'm at high risk of delivering a premature infant, and aren't there capabilities that could support me in my day-to-day life that didn't depend on me trucking into a healthcare system to receive care? Or what if I was a young man with type 2 diabetes, a high schooler who's trying desperately to live as normal a life as I possibly can, and knows that there are kinds of technologies out there, whether it's artificial pancreas or whatever else, that could really assist me in managing my condition, but also enable me to have a life outside of the healthcare system. And on and on and on and on and on. As we came up with these scenarios, it really began to seem that it was a no-brainer exercise that healthcare without walls could reach a lot of people much more effectively than our current system. So why weren't we building that even faster? As we looked around, we could see pieces of this desirable future all around us in pieces. And it reminded us of the statement made by the famous science fiction writer William Gibson, who said, the future has already arrived, it's just not evenly distributed yet. Because we can, in fact, see pieces of this all over the place. So, fast forwarding from the Jetsons to the 1990s, we know back in the 1990s at the University of Texas Medical Branch, there was active healthcare being delivered to prisoners in the prison system in Texas in 1994 and 1995 was the first pilot showing proof of concept that yes, you could effectively manage many prisoners' medical conditions through these remote technologies. 1994 and 1995, right? So the future had arrived to some degree then. It involved prisoners because it was okay to see prisoners at a distance. We would never inflict that on normal human beings, right? But prisoners, we would make an exception. I don't mean to downplay the importance of this work. It was very important, but you can see where it was necessary to make accommodations in the system. We were willing to do that for certain populations. Why weren't we willing to do it for everybody? Now, we fast forward from then to now. We know that there's been although this article, research letter in the Journal of the American Medical Association from last year showed that telemedicine is still rather low levels of utilization in this country. Nonetheless, it has risen quite substantially in recent years. And not surprisingly, many of the users of telemedicine now are younger people, using it to access primary care and other interventions. And interestingly, you think about in a case like Texas, telemedicine has been used to travel across, extend care across vast distances. Now we're seeing telemedicine crop up, especially in dense urban settings, where there's lots of access to healthcare providers. So it's not necessarily access that is driving this now. It's also convenience and younger people wanting to have their needs met more in a more timely way than has been the case typically. So back to the notion of the future having arrived, but being distributed unequally. Down the road here at Round Rock, as we know, at Texas State University, advanced practice nurse training now is training these APNs to deliver care at a distance. And one of the really interesting models is what they have come up with by dint of the so-called Pregnant Family Project, recognizing, I think, belatedly that it's not just the woman who gets pregnant, it becomes an event in the entire family. So thinking about ways to use virtual care delivery, work closely with families that are experiencing a pregnancy, counsel patients on their health issues, and use all available modalities, not just telehealth, but also telephone, FaceTime where necessary, and essentially narrow the gap between patients and the clinical system that can support women and families in the community as they go through the pregnancy experience. So again, future has arrived, just unevenly distributed. And then when we think about the kinds of technologies that are going to be coming into the system, are already here to some degree and will be much more prevalent in the system, we think about things like Figure 1. Does anybody here know Figure 1? Okay, Figure 1 is an app. It's now being used by 1.5 to 2 million people worldwide, clinicians largely. You can download the app on your phone if you're a clinician, and you can use it to send images of your patients, de-identified, it has to be HIPAA compliant, de-identified images of your patients, and you can, in effect, crowdsource medical knowledge. So I could post an image and say, I want all 1.5 million people to tell me what they think this patient has. Or I can make that ask more discreet. I can say, I only want Fred, Mabel, and Ethel to tell me what they think this is. But this is today a tool that is in increasingly broad use, and you can see the power of this. This essentially basically collapses the distance between people who have knowledge and puts them together with people who need that knowledge very fast to enable people to be better clinicians. And you know by looking at this that if this tool is available to clinicians today, how many years do we think will go by before these kinds of tools are in use by patients? And patients are crowdsourcing medical knowledge through basically taking a picture of, say, some dermatological condition and asking the universe to comment on what it might be and how it might even be able to be self-managed, right? So these are the kinds of platforms that are going to be coming into the system in an even greater degree. What does that mean for healthcare without walls? Another example I love to invoke is this one. This fellow, Ray Dorsey, is a neurologist up at the University of Rochester in New York State. And he sees primarily Parkinson's patients. And he has quite a number of them. He has not set foot in a physical clinic in 5 years because he sees all of his patients virtually. Why does he do that? Because Parkinson's patients, as you can well imagine, have difficulty getting to appointments. Most of them no longer drive. If somebody takes them to a neurologist appointment, it means that there's a caregiver who's taking the better part of the day off work to take the patient there. Ray's work has shown that of all the people on Medicare who are diagnosed with Parkinson's, only about 60% of them actually see a neurologist. 40% go through the entire stage of Parkinson's from diagnosis to death without ever seeing a neurologist. And part of that is just sheer lack of access, physical access, as well as in some cases, obviously, financial access. So Ray said, this shouldn't be, and has essentially set up a program where he sees his patients largely virtually. He was involved in a large national multi-site trial that was funded by the Patient-Centered Outcomes Research Institute that tested this whole concept of virtual house calls for patients with Parkinson's disease. It was a randomized trial. It was a population in standard care involving physical visits only, and then the trial population was some physical visits married with the virtual visits. And I'll just flash forward and tell you, here were the results in terms of patient satisfaction. Now you can see not everybody completely was on the same page, but large numbers of patients either thought that they had a better personal connection with their clinicians whom they saw virtually than the patients who saw their clinicians physically. Certainly most patients agreed that it was much more convenient. Many thought it was more comfortable. And a very substantial number actually preferred the virtual visits overall. Now, why would you prefer that other than the fact that you didn't spend 4 hours on average to have a half-hour appointment? Obviously, you were able to have longer conversations in some instances, in some ways, some respects, more intimate conversations, even virtually with clinicians, etc. So we have proof of concept that these things can work. Telehealth, broadly, has been taken up to some meaningful degree within the VA system, again, for obvious reasons. It's a system that doesn't have to worry about licensure issues among clinicians in one state versus another state. It has to work within a budget. It has to see as many patients as effectively and efficiently as possible. So the VA has really begun to make very significant investments in telehealth. As you can see, in 2017, more than 2 million encounters involving vets being monitored at home via cell phone for various conditions. And lots of vets now wearing Fitbits and other wearables as they share information with clinicians and as people figure out how to use that and harness that information to incorporate it into meaningful care. We know just not too far away in Arizona, lots of experimentation around the use of virtual care in the pharmacy context. And a spin-off of a University of Arizona company now undertaking what's called medication therapy management, essentially largely virtually, not only doing it in Arizona through the College of Pharmacy at U of A, but also partnering testing the model out at Ohio State. Essentially establishing that medication therapy management, these exchanges between pharmacists and individuals around their medication adherence issues, dosage issues, et cetera, all of that is really, really effective, especially for elderly patients who have transportation issues. And of course, we know that those are people who are taking a lot of the medication. So again, the future has arrived here. It is just not very evenly distributed. We know that it is becoming more distributed. We know back east in New York City, a lot of the Walgreens pharmacies now are equipped with kiosks that enable patients to come in and have direct consultations with clinicians in the emergency department at New York Presbyterian Healthcare Center. The head of New York Presbyterian told me a story last year about a man on Medicaid who came in with sort of classic chest pains. Couldn't get himself to get on the subway and get all the way up to New York Presbyterian, but was able to get down the street to this kiosk, and in a matter of minutes established through his consultation with the ED docs at New York Presbyterian that he possibly was in the throes of a heart attack. They sent an ambulance and got him up to the facility. Now, in a perfect world, he would have known enough to go right to the ED with chest pains, but it's not a perfect world. And having these kinds of capabilities obviously will probably become much more widespread and much more important in the provision of care. As we know, CVS is merging now with Aetna, the health insurance company, and the goal, as stated by the CEO, is to reinvent healthcare and essentially refashion the front door of healthcare. so that the front door of healthcare will increasingly look less like the conventional doctor's office in his view, and more like a version of the CVS stores that now are within reach of probably 95% of Americans. And essentially you can see the goal there. We're going to transform the consumer healthcare experience, build healthier communities through an innovative healthcare model that is less expensive, closer to consumers, and easier to use. So over the course of this year, we're going to see a number of prototype CVS stores around the country be stood up and reconfigured to be this new front door of healthcare where people can come in and have consultations with pharmacists, with nurse practitioners, as is already the case in the CVS Minute clinics, and with others, and with a very robust electronic health record system, which CVS has invested in, that will basically connect them with primary care providers and even academic medical centers in the surrounding area. So a very interesting new model. We'll be watching to see what happens. Think about the technology companies now that are creeping into healthcare in various ways. And of course, Amazon pops to the top of the list. If we think about Amazon, which now has 90 million people willing to pay, I think it's now, what, $129 a year to be a Prime subscriber. More than 100 million people worldwide. That's a big pool of people who trust Amazon in their day-to-day lives. The company shipped more than 5 billion items in 2017. It has bought PillPack, which is a distributor of packaged medications that are specifically packaged for people who have to take multiple medications and get confused about which meds they have to take and when. PillPack packages them all up and disperses them to people. PillPack has licenses in every state to do this work. That's why Amazon bought PillPack. It now is licensed as a pharmacy provider, pharmaceutical dispenser in every state in the union by virtue of its ownership of PillPack. Amazon will be in the pharmaceutical distribution space within a matter of probably months, certainly no more than years. That was one of the big motivators of the CVS Aetna merger. So you guys could see Amazon coming into its very important pharmaceutical distribution space. So what else can you do on Amazon? You can buy things like this device you see off to the right here. This is an otoscope that can be plugged into a smartphone so that if you're the typical family with young children that gets up worried whether your kid has an ear infection or not, or just a cold, now what you can do is take a picture of the inner ear with this otoscope and send it to your pediatrician to basically make a judgment about whether this ear in fact is infected or not and merits the child going on antibiotics. I have 3 kids. I would have killed for this device when they were little. But now you can buy it on Amazon for $48.99. Now, I use this example, but a friend of mine pointed out to me recently, you actually can get a much cheaper one for less than $20 as well. So think about the world where Amazon is in the homes of at least a third, if not more, of Americans on a regular day-in, day-out basis. It is distributing pharmaceuticals to them, and as we know, Amazon is investing heavily in drone delivery, so probably drones will have a piece of that in the future. And it can also sell you all manner of devices for self-care. If it wanted to, it could go into telehealth or telemedicine tomorrow by hiring a corps of clinicians who would do that. So do we think they're never going to do that? I don't know. But this is the kind of capability that you can imagine very quickly transforming the way most Americans are used to receiving health care. And they're not alone. Almost every other major retailer in America is looking one way or the other at how it has a healthcare relationship with people. And one other example is Best Buy, which bought last year this company, Great Call, which makes a kind of a really sophisticated high-tech version of those Lifeline commercials that you see on television where somebody, I fell and I couldn't get up, right? But I had this Lifeline device. This is a much more sophisticated Lifeline type connection technology package that is provided now to enable individuals to stay in their homes longer and also have direct connectivity with their healthcare providers, also with relatives, et cetera, and tied into a personal emergency response service. So that is now owned by Best Buy because they recognize that these are the kinds of appliances and technologies and capabilities that people are going to want in the future, and they will be there to provide them. Now, we know that there are tons and tons of these technologies already out and many more in the pipeline. And they go all the way from, at the most basic level, telehealth. And let us not kid ourselves, telehealth can be Skype, right? It's not that necessarily that sophisticated. Skype is how Ray Dorsey does his visits with his Parkinson's patients. So it's all the way from pretty garden variety technologies, quote unquote, like Skype, to all manner of artificial intelligence, machine learning capabilities, internet-enabled devices, the Internet of Things, the Internet of Medical Things, apps, mobile apps, and then on to things that are in the pipeline but will be increasingly prevalent, lab tests, self-administered lab tests, autonomous cars. Kaiser Permanente has a wonderful series called Imagine Healthcare, where it imagines a future where if you are walking down the street and you have a heart monitor on you that detects an irregularity, an autonomous car arrives to take you to a clinical appointment, right? It's not so far-fetched. And then, of course, drones. And as I say, Amazon and UPS already investing heavily in them, and one of the primary perceived means of use is going to be probably delivery of a substantial amount of medical supplies. So it's all coming if it's not already here. And case in point, we now have the Apple Watch enabled with EKG capability. And I'm told there will be a major study released next month at the American College of Cardiology proving out the utility of this Apple Watch in detecting early heart arrhythmias and other issues that lead to early intervention that saves lives, so we will see. We know that the technologies of machine learning and deep learning are increasingly being applied to various aspects of care. This is just a quick glimpse at some research that was done at Google Brain, where essentially a deep learning system was created to essentially look at, across the board at these images of essentially of the retina and begin to assess which patients had diabetic retinopathy. And in fact, now by training these machines in effect to scan these images, to understand these images, to identify what is retinopathy versus what is a normal retina, you can actually now have this done by machines at least as well as, if not better, than most human beings. So think about the applications to all kinds of imaging that goes on in healthcare, and we get a sense of what the future will look like there. Now, it's possible to obsess about the technology, and we frankly should be obsessing about the technology because there are lots of implications to the use of these approaches, but it is also not all about the technology because really it's about putting technology and people together in health systems in new and different ways. People are not going to disappear, right? People are going to be doing different things with the assistance of technology. And so that becomes, I think, a critical question that those of us who are in the business of health professions, education, or training have to begin to think about. What are human beings going to be doing in healthcare 10 and 15 and 20 years from now that they're doing differently today or not doing today, and they're going to be doing things differently because there is technology, right? That is really the essential question. And what's the potential of all of this? If we really could capture all of the benefits of putting people and technology together in new ways. We know we could drastically increase the convenience of care. That's why so many young people want to have telemedicine visits with doctors, even in urban settings. We know we could increase access, especially in underserved areas. We know that we could leverage and extend the existing provider base. In Healthcare Without Walls, we fantasized, what if you treated the healthcare workforce kind of like the electrical grid? And when there's demand surging in one part of the country and ebbing in another part of the country, you could kind of move the supply of healthcare over to the demand surging areas. In other words, why couldn't you have, for example, docs in California where it's still, 3 hours behind the East Coast, still delivering telemedicine care to people on the East Coast because their doctors have already gone home for the evening, right? I mean, you could do this. Why don't we think about leveraging the existing provider base in that way? Why aren't we focused on universalizing and democratizing the knowledge in the system very broadly? Crowdsourcing the knowledge, with Figure 1, of the best medical knowledge. Why would we think it has to be confined to, for example, the Mayo Clinic, or MD Anderson, or Memorial Sloan Kettering? Why shouldn't you be a patient on Kodiak Island, Alaska, and expect and be able to have a visit with somebody at MD Anderson via telehealth, right? So dealing with all of that and then reducing all of the unnecessary friction that exists in the current healthcare system that doesn't buy one iota of health, but that saps productivity, that produces absenteeism from work. At the University of Virginia at Charlottesville, where they've had telemedicine across 65 specialties for more than a decade, they estimate that they save patients in the states 18 million miles of driving just by virtue of having telehealth capability. How much driving captures increments in health, right? So thinking about getting the friction out of the system and capturing really the true aspects of health and healthcare that do engender health seems very important. We think the potential is enormous to address social issues in communities, as I said earlier, that contribute to poor health, that meet patients where they are, or as we call them, people where they are, because most people who would otherwise be classed as patients prefer to think of themselves as people, living their lives, having just the connections with the healthcare system that are necessary, but no more to keep themselves as healthy as possible. Now, are there any downsides to this? Absolutely. And as those of you who read the book know that we dealt with a lot of these. And downsides, and even maybe not even downsides, but things we have to think about. Human factors considerations. How do we make technologies that are really usable and useful for all populations, including individuals who are elderly, disabled, have mild cognitive impairment, etc.? Do we have to worry about utilization soaring if we made it so much easier to access these technologies? That's been a real reason why payers have traditionally been reluctant to pay for telemedicine. They've been afraid that all of us will sit at home and say, you know what, I feel like getting a medical appointment today, and go online immediately to have an unnecessary telemedicine visit. We have many privacy and security concerns around the flow of health information. Now, much of which is still occurring within the HIPAA context, but much more is completely outside of the HIPAA construct. If you have a Fitbit, not one iota of the information that's being collected about you and shared with Fitbit is HIPAA protected. You have given that company your health information, and more health information will be like that. How do we keep that private and secure enough to satisfy our own needs for security and privacy and dignity? Are these technologies going to disrupt existing business models? Absolutely. Many would argue that that should be what happens. Well, it's going to be painful. As healthcare moves out of institutional settings, there are implications for employment, among other things. That will be hard for communities to work. And there's probably much, much more. There are a lot of obstacles that have to be overcome. As you know, we spent a lot of time on this in the book. How are we going to deal with issues like devising the kinds of payment models that will support these new modalities of care? How do we deal with state laws and regulations that still stand in the way? For example, even a provision of telehealth. I'll just mention the example, telehealth and telemedicine in Texas. As we know, this state really has been at the leading edge of innovation around use of telehealth and telemedicine. Going back to that example I showed of telehealth to the prison system in the 1990s. But there's still impediments. Under Texas Medicaid, patients who are getting virtual care still have to be in an eligible originating site, quote unquote. They can't be at home, right? They have to be in a medical-led site or a school or a mental health facility. Does that make any sense in this day and age? Texas also is not part of the Interstate Medical Licensure Compact, which enables the 25 or so states that are part of the compact. In those states, a physician who has a license in state A can get an expedited license in state B if that state is part of this licensure compact. Half the states are not part of that. Now, I'm told it's still possible in Texas. You can get, if I'm a clinician in Oklahoma, I can get an expedited telemedicine license to practice in Texas. But you can see it's still kind of an artificial barrier that we have left over from another era where we thought states have to hold all the reins in terms of licensure of clinical professionals, and is that really appropriate in this day and age? So we came out with a number of recommendations in our book. Those of you who read them have them, and I won't spend a lot of time on them because they're kind of lengthy, but just to quickly encapsulate some of them, we said very clearly that we have to create some kind of a regime in this country that drives all of this in the right direction. So that makes sure, for example, that the technologies that are developed are usable by many different types of patients, are transparent, so you understand if you have a machine learning system, what is the algorithm that underlies that, in effect, that machine and its assessment and, in effect, decision-making. That has to be transparent and auditable so that we as human beings understand what is the basis of these technologies. What I mentioned, payment in healthcare, as we know, is a huge, huge issue. How do we devise a payment system that doesn't spur unmitigated utilization, but does spur getting the right care to the right patient in the right way at the right time? On the regulatory issues, I've already said a good bit about that, but there's a whole raft of regulations that were created at the federal, at the state, and at the local level that grew up in the old era of healthcare for quite legitimate reasons that don't make sense in the current era where we have a very different set of avenues available to provide care. And as far as the workforce goes, one of the very interesting phenomena that we learned as we went through our work is that if you take all the existing workforce projections in the healthcare system, for example, the American Association of Medical Colleges regularly puts out analyses that show that we face a massive physician shortage in the country. You will see comparable analyses around the nursing workforce, et cetera. How many of those workforce projections do you think make any assumptions whatsoever about the take-up or use of technology? Anybody want to guess? Make it easy for you. Zero. Zero. The AAMC makes no assumptions about use of telehealth, how that will change clinical care delivery, how many physicians you will need to provide telehealth versus have physical visits. So all of our projections are frozen in time in a way that is completely unrealistic. So what do we do about that? How do we decide how many medical schools we need, or nursing schools, or how many people to train? We don't have a roadmap for that now. We've got to develop a better roadmap, and we've got to understand, very importantly, what do we want to accomplish, what can we accomplish, and who do we need working with these new technologies to accomplish that. And that is really important and difficult work that really lies at the doorstep of everybody now who's running a school of health professions education. And then the whole array of human factors issues, as I mentioned earlier, and we called for really having what's known as human-centered design be at the bedrock of all development of all healthcare-related technologies. So we don't go down the road as we went down with electronic health record systems, for example, of devices systems that were designed for one purpose and then end up getting used in a very different purpose and not rising up to the task. So this challenge of reimagining the future of healthcare and reimagining, as I say, healthcare education and training for this new era is immense. I think it's going to require experimentation, a lot of it, and of course the academic community here is very well suited to thinking about the kinds of experiments that we're going to need to mount, the randomized controlled trials, the other kinds of studies we're going to need to do to figure out how to do this right. We're obviously going to need a lot more research to compile evidence of how best we can improve health outcomes. We're going to need a lot of advocacy at the state and federal level to remove the barriers to innovation. And we're going to need a lot of collective reimagining of the system from multiple perspectives. So with that, those of you who have not yet had a chance to read the book, if you are so inclined, I will say you can request a free copy from NEHI at this website. If you just go to nehi.net, it will guide you through to request a free copy, which is available to people from a charitable or nonprofit institution. I hope that some of you, not because we're going to make a lot of money off of this book, we're not, but we want to get these ideas out because the ideas are powerful, they are exciting, they are unnerving for many people in the healthcare system, but they're important because we think they can get us to where we really want to be, to a system that gets health, not just health care, to all people at the right time, in the right place, in the right way, using the genius that we are able to bring to bear, and that so many of you, I could tell from the posters already today, have been able to bring to bear to make the system really worthy of the name, a health care system for all Americans. So, thank you very much. It was a pleasure to be with you.
Susan, thank you so much. I think all of us at Texas State, especially our health researchers, benefit so much from hearing the national and global experiences and from the lessons learned, not from your long career, but from your distinguished career. So thank you so much for being here. We're going to now transition to our panel. So I'm going to ask the panel to please come up on stage. At the end, we'll have Susan available and the panel for some discussion and questions if we have time. But I'll bring the panelists up. Let me begin by introducing the moderator for today's panel, someone all of you here at Texas State know very well, and Emily Bradley, our Provost and Vice President for Academic Affairs, Dr. G. Boucher.
I think we're ready. Well, thank you again, Susan. I had the pleasure of meeting for about a half an hour with Susan earlier. Walt brought her by my office, and I will say, I'll repeat it again, I tend to be someone who is quite optimistic, who sees glasses, not half empty or nearly empty, but half full or almost full. But after reading the book, which I've been reading over the last 3 months, I told her that it's a humongous challenge facing us. I was just, again, as a layperson, stunned by all of the detailed complexity of our healthcare system that just goes so much more beyond me going to visit a doctor, which I typically, as you've heard in the last 2 years, don't do. My wife does a lot, I don't. That's a problem for many of the males in the audience, typically. The payment systems, you go and pay something, somebody takes some money out of my check every month for health benefits. but it was all of the deep layers underneath just those three aspects of the healthcare system that I was just blown away by. So we're going to bring Susan up at the very end of the panel, and I will be asking her a question about this volume system versus something else that I think probably plagues our healthcare system more than anything else. So it's my pleasure to introduce our panelists here. Our run of show, we're going to run for about 30 minutes, and then we'll have about 10 or 15 minutes for Q&A at the very end. Representing Texas State University is an alum, Mr. Tom Kowalski, President and CEO of Texas Healthcare and Bioscience Institute. Tom? Senam Goni is the founder of Narrative DX. Senam? Laura Belcher is the Executive Director of the Texas eHealth Alliance. And representing us right up the road now, actually, Heather Path, Director of External Affairs for the Global Digital Health Technology Hub at Merck, which is embedded within the Dell Medical School in Austin. So I'm going to begin with a few words. So obviously the theme of the showcase is smart and connected health innovation. And we hear the term smart all the time. Smartphones, smart cities, even our refrigerators and microwaves are smart. Although they still don't clean themselves. I'm not too sure how smart they really are. But if we look at statistics for Texas and across our nation, it's not really clear that we are as smart as we need to be when it comes to healthcare and healthcare innovation. Estimates from the Partnership to Fight Chronic Disease indicate that the state of Texas alone spends as much as $166 billion on chronic illness, such as diabetes, cancer, high blood pressure, and conditions related to obesity. And the state loses a projected additional $66 billion in work productivity due to chronic diseases. The situation in Texas, as you've kind of gotten, is not much different from the rest of the country. The Commonwealth Fund published a study in 2016 showing that Americans are more likely than people in other countries to have more than one chronic condition, such as arthritis, heart disease, asthma, high blood pressure, or diabetes. 28% of Americans have chronic health conditions, compared to 14% in the United Kingdom, in the Netherlands, 18% in France, and 22% in Canada. On top of that, according to the 2016 study, we spend $9,523 a person a year on medical expenses, which is far more than most other developed countries. Health spending now tops more than $3 trillion a year. So I think, as you heard from Susan, and from those brief words and what you all in the audience know, if we don't do something to change this trend, both Texas and the nation will be described by two words, as Walt puts it, sick and broke. So we have to fix this. So I'm going to ask each of our panelists to talk about a key area where we're doing well and we must continue to innovate in an area of health. And we're going to start off with a topic. That area that you're familiar with or that we need to be familiar with, where we really are in need of that innovation or that's something that could be a game changer. And so we finished sort of with some machine learning, so I'm going to turn and ask them to talk about machine learning. Do we need to innovate in that space?
Absolutely. I actually would love to hear first from colleagues on this panel who are involved in the sort of clinical outcome side of healthcare. What I do, and with machine learning, healthcare is on the service side of things. But, and I'll just speak from my little corner. In the few years that we've been growing Narrative DX is about using machine learning, artificial intelligence and machine learning, natural language processing, amplifying the patient voice, which is very much about the delivery of patient-centered care. And we started Narrative DX because we realized that there was a significant void on the service side of healthcare, service delivery, to bring really emphasis to patient voice. And the only kind of data, really, the only kind of evidence basis that you can build out of patient voice is narrative data. And building and creating trends and actionable insights from that kind of data can only happen through machine learning-based, AI-based technologies. So that's why we started NetDX and what we are doing in that space, as I said, and I can talk very much about how the service side, the experience side, is actually a very critical component of healthcare outcomes, especially process of care measures in healthcare. But I will first sort of give the mic to...
So we may just go down the line here and then people get the mic here.
better first on the clinical outcomes of healthcare.
Yeah, so it's a thrill to be here, and I wanted to talk a little bit about how I think it's a really cool time to be around and to live through the technological revolution that we're all seeing. I mean, who knew back in the 80s and 90s when the internet started to become a thing that, you know, a couple of decades later, you know, we'd be, as Susan mentioned, you know, the Apple Watch, I'd be, you know, talking into my watch because of the phone. Well, it's also monitoring my heartbeat, and I'm also, you know, sending texts and emails, which I didn't even know what that was 20 years ago. So it's a great time to be around, and I think that one of the things where I think, so technology is obviously doing really well, and I think one of the things where we could sort of, an opportunity for growth is sort of changing the human mindset. You know, we're at a perfect storm right now of technology and data, and our culture is really sort of wrestling with how are we going to deal with that perfect storm. And just one example is my mother. She's a 78-year-old, she's 78, she lives in rural Oklahoma, and she had a pacemaker installed last year. And it kind of freaks her out because, you know, the doctors and the healthcare providers in the biggest city that's close to her can monitor what's going on with her heart 24/7. That's just like, you know, what are they going to do with that information? It just freaks her out. And I, of course, think it's great because I'm going to have my mom longer. And I even called her this morning and to make sure I was going to characterize her feelings about all of this technology properly. She said, yeah, you know, I mean, you know, you see those little things that you can put over the videos on computers so that people can't see you. And I keep looking like, where is that video of this pacemaker? So I covered it up. Okay, Mom, we'll talk about that later. But so that's sort of, you know, I'm not going to change my 78-year-old mother's mind on this, but I think we have to. Our culture, like I said, is wrestling with this, and you know, the technology hasn't just caught up to humans; it's surpassed humans, and really the burden is on us. You know, how are we going to deal with it? And I think also something that's important that people in our industry and all industries really need to be thinking about. And Susan, you touched on some, and that is the workforce. And you know, we're very proud at Merck to have recently hired, he's just 90 days into the job, a brand new CIO who came to us from Nike. And he's, you know, his title is Chief Information and Digital Officer. Digital was never part of that consideration before. And he's in one of the reasons that Merck opted to open a digital health technology office in Austin is because of the access we have, both the access we have to top technology talent, because of all the talent that's in the Central Texas area, but also, and frankly, this is one reason why I'm here today, it's the college and university system that we have access to, the research and the students and the expertise and the talent pipeline. And I understand here at Texas State, you all not too long ago launched a PhD program in computer science, and we're really interested in hearing about that. So I think just making sure that the leaders that the workforce that's being trained is prepared to continue to lead us through this technological revolution.
Well, good afternoon, everybody. As Gene had mentioned, my name is Tom Kowalski. I'm the CEO of an organization called the Texas Healthcare and Bioscience Institute. Its acronym is THBI. We were created in 1996, and at the time that our organization was created, we had about 500 life science companies in the state of Texas, and there was a group of entities that got together that said, you know, we need to change things. We need to begin to look at policy in terms of how to grow an innovation society within the life sciences in the state of Texas. At the time in 1996, all of our companies were leaving. They were going to California, they were headed to the Carolinas, they were headed to Maryland, they were headed to New York. All of our grads were leaving. We did not have any venture capital that was interested, but yet the research through our academic health science centers and our universities, the research was booming. And NIH grants were flowing in, but yet all of the ideas were flowing out. Well, let's fast forward to today. Today, we have 5,500 companies across the state. All of our major metropolitan areas are very organized. Angel investments are organized in all the major cities. And it is a statewide footprint. If you go to our website, thbi.com, we just published a report that we issued about 10 days ago that literally looks at the innovation capacity that we have in the state of Texas. So where I come from, and I agree with everything in your book because I have a pinched nerve, and I'm having heck getting in to see my doctor and spending countless hours in time that we do not have, and it's very painful. So I'm on board. Anything I can do to help push your book, I'm in. I'm there. But anyway, but if we look at both the economic impact that it gives the state of Texas, you know, at the end of the day, innovation really affects the patient or the person. And so the innovation is very much alive and well. But one thing to keep in mind, all innovation, particularly in the life sciences and in the healthcare field, it is driven by policy. And policy both on a federal level and on a state level. Different set of rules for both the state and feds, different set of political parameters. We're seeing it unfold right now on a federal level with the hearings that are being held. It's a changing dynamic on a federal level, but yet it's also a changing dynamic on the state level. So where I come from and what I've been focusing on the last 23 years is if policy will hinder innovation. And at the end of the day, it's really the patient that's the true beneficiary of what we're creating out of this innovative society. We're doing some amazing things in the state of Texas. So one thing I can point to is a secret. How many of you all are familiar with the Cancer Prevention Research Initiative here in Texas? It's a $3 billion program over a 10-year period, $300 million a year. We're two-thirds of the way through this program. $2 billion have been spent. We're now having some wonderful discussions on what a secret 2 might look like. This is a big thing for the state of Texas. Big ideas, big things, lots of money. It's the second leading organization out of the NIH that is granting money. It recruits talent, it matches grants, it creates companies. So the state of Texas is actually taking equity positions in companies that they're creating, which is a first. It's a new dynamic for the state. But the conversations alone out of what a secret 2 would look like, now and secret is really oncology based, it's cancer driven. Now we're looking at mental health. So we're not only talking about oncology this legislative session, but we're also talking about some major mental health bills. So we're recruiting talent, we're matching grants, we're putting money into companies. Big things, big ideas, a lot of money for the state of Texas. I think it's very exciting. The next decade is just going to be phenomenal. And we all have a lot to be excited about. And I hope we can get the telemedicine in our homes. I'm with you.
Well, isn't that a nice segue, Tom? Thank you for setting me up. I'm Nora Belcher with the Texas eHealth Alliance. We represent digital healthcare companies and organizations. We're actually modeled after THBI. I even stole Tom's bylaws when I started this association 10 years ago because THBI had shown the pathway for bringing industry together to work on policy. And when I started and I put telemedicine vendors and EHR vendors in the same room, everyone thought I was crazy. They don't have anything to do with each other, I was told. Susan would say I was right. And I want to thank Susan specifically, before I get to kind of the commentary, for the shout out for Senate Bill 1107, which was our landmark telemedicine legislation. I led the coalition to pass that bill. And just the other day, we got Medicaid to agree to allow the home to be a side service for the very first time for Medicaid patients. Policy drives change in the healthcare system. I have worked on telemedicine legislation in this state since 1997. I was 12. It's very clear, it was a prodigy. But the policy process is where we have been able to drive the change. And it's interesting, we had one big piece of legislation in 2017. This session, I was making a little list as I was listening to Susan talk. We have teledentistry, telepsychiatry, teletrauma, telemedicine for sexual assault nurse examiners, telepharmacy, telemental health, telesubstance abuse disorder treatment, telemedicine for schools, and telemedicine for opioid treatment, all pending in the legislature. Because all of a sudden, telemedicine is a hot topic. And that's good and that's bad. Because one of the things that I tell stakeholders when I'm in front of any audience, and it includes this one, is if you don't know what business problem you're solving with telemedicine, you don't have any business doing telemedicine. This is not something that you buy off the shelf, because we did this in the 90s. We funded a lot of equipment, we installed it in hospitals, we forgot to tell them how to use it. We forgot to tell them how it was relevant to their business. So part of where I think folks like you can really help is in breaking down those operational conversations inside all these different areas of practice and helping us dream and think about what does telemedicine look like in teledentistry. And I'm not just talking about whether hygienists can have independent practice. I'm staying out of that fight. But the question is, we know we have underserved areas. How to use the technology to bring the healthcare to those underserved areas. So there's a big policy discussion that is now starting to touch all these untouched, unrevolutionized areas of the healthcare system where the consumer is still the supplicant, right? Like Tom is saying, you show up and hope someone will see you. What kind of a world is that? That should not be acceptable to anybody in this room. It's also a women's health issue because caregiving falls disproportionately to women. And so anything that we can do to kind of shorten those time frames to care has an impact there that has a bigger feel than just that immediate provision of healthcare. And then the last thing that I'll say, how many of you have ever read that packet that comes with your insurance? Actually read it. I don't mean skimmed it, because I'm the one everyone in my family calls when that packet shows up. I guess most of the people in this room actually have access to a telehealth benefit right now. You're probably insured by a plan that has Teladoc or MD Live or a service offering like that. Anyone in this room, have you done it yet? Okay, I see some hands up. Take a look at that. Ask the question. Go to your insurer's website, because utilization is not where we like it to be, and that starts with education, and that starts with patients simply knowing whether or not that's an option for them. So we have a lot of work to do, but I like to make that flag anytime I've got a room full of people, because that will get utilization up, and at the end of the day, that matters, not just to me as a policymaker, but if it means you got to see it in 15 minutes instead of taking 3 hours out of your day, that burn to the system that Susan was describing, we tighten that. Researchers are so please capture that and find ways to write that down and publish it. That's all. I don't ask for much. I'm a simple girl with simple needs. But I'll stop there, Gene, and turn it back over to you.
Well, before we transition, I'm going to let Sim talk a little bit more about, again, machine learning and AI. But in the Austin American-Statesman a couple of weeks ago, this article from an AP reporter, Telemedicine's Challenge, Getting Patients to Use It. That was the part of the article which you basically just touched on. I think in addition, the article hinted that in certain states, there wasn't as widespread access to certain parts of the telemedicine kind of portfolio. And that should be changing, hopefully, with some legislation.
So Texas was actually the second to last state to fully go direct to consumer. Arkansas, still a problem. But those barriers have fallen, and for those of you that are legal and political science nerds and you like to read about interesting things, there's an aspect of this that relates to the Federal Trade Commission and a case in the Supreme Court about the dentists of North Carolina trying to regulate their own competition out of the market. The Supreme Court ruled that people who are part of a profession, who are also the regulators of that profession, can't just willy-nilly make up rules to keep technology out of the market. That was really significant, because those regulatory boards have enormous authority, and for the Supreme Court to say, it's not enough for dentists to say the tooth whiteners at the mall, which was the real case, are practicing dentistry illegally and try to get rid of them. That has helped the states be able to evolve their policies because a lot of the control lies with those regulatory boards. And the Supreme Court, they hit them hard. And it has changed the regulatory conversation in a way that can only be good for consumers. Because with all due respect to any practicing healthcare professionals in the room, the tendency of more than 3 people of any one tribe is to protect their tribe. And to get to the revolution that Susan's describing, we're going to have to be less tribal and more global.
I just wanted to say that, and you're all here talking about innovating care delivery models and creating a better system for care delivery. And artificial intelligence is a significant part of it because it is the cutting edge technology. And I find myself in this awkward position always as the founder of a company that is providing artificial intelligence to a specific space to talk about it. I don't find myself qualified to. I'm a social scientist. I have a team of data scientists who brought the technology to this space where I realized there was a need. But I just wanted to reiterate the fact that everything that we heard from Susan, from the panelists, is about creating space for the patient's voice, and a technology like artificial intelligence brings that kind of capability to actually make it a reality to provide patient-centered care delivery. Because artificial intelligence at the end of the day is statistics on steroids that allows you to recognize patterns in very specific contexts of experience, of interaction. So at Narrative DX, we saw the opportunity to bring that to a space that was opening up because of regulatory changes in the industry. Value-based purchasing made brought a lot of attention, financial attention to patient satisfaction, which has always been part of the clinical mission in the industry, but it brought a financial incentive to what are patients really saying about the care that they receive. And I think that is at the core of any innovation that we can speak of to make healthcare delivery better. And artificial intelligence is another type of innovative analytical capability that would make that kind of leap happen, that would put the patient at the center of care delivery where he or she belongs.
So you're here on our campus. You have in front of you, several hundred faculty members and others, not just at Texas State, but from other institutions. And they are entrepreneurs and innovators. Again, Susan, I shared with you that I really do believe that the DNA of this institution in particular centers around, obviously, an understanding of the basic, the foundational, the theoretical research that can underpin applied or translational research. I think here we excel in that aspect of seeing a real world problem and then trying to find a solution to that and other real world problems. So I'll ask all of you, you have an audience here who wants to hear about some opportunities. They're already working in some areas. You can see the posters and kind of do a deep dive with some of their more specific research interests. But are there funding opportunities, other policy areas, other technological areas that they need to be working in, or that they may find useful in terms of partnering amongst themselves or with other entities and agencies, including the private sector every now and then?
Again, speaking from my corner of the world and patient experience, there's a lot of dialogue in my industry about how important it is to talk about the experience components, service delivery component of care as human experience in healthcare, talking about patient experiences, talking about only one side of that coin. There's a tremendous need to understand provider experience. We can't understand, improve patient experience without understanding provider experience. There's a lot of work already being done on clinician burnout. What we need to do to reconnect providers in this fast-growing industry to the purpose of the work that they do, the reason why they signed up for this profession, and implications of that for service delivery and patient experience. Again, given an example from my company's perspective, we brought AI to patient experience by analyzing verbatim patient feedback, but very soon, in our infancy, we realized that we couldn't leave out employee feedback in healthcare if we were to leverage the voice of service delivery in healthcare. So I think there is a really interesting work yet to be done at that intersection of the impact of provider experience on the delivery of care.
So I'd like to talk about soft skills. As I mentioned, one of the reasons that Merck decided to open an IT office in Austin about 18 months ago was because of access to top talent. But also, my predecessors and the people who hired me did the national search to select where the site was going to be. And in our office, it's not just folks who are fixing printers and teaching you how to use the newest version of Windows 10. We've got computer scientists and data analysts and data visualization experts who are really doing R&D and developing software and thinking through how to take our company on the journey through this digital age. And one of the things, so my role at Merck, I didn't introduce myself when I started to speak, but my role at Merck is I oversee in the Central Texas region external affairs, and that means I work in communications and public relations and public policy and advocacy. And to my colleagues in my office, I have a lot of really smart tech geeks that I work with in the office, and they're wonderful, and they think that what I do is like magic. And of course, I think coding and what they do is black magic also. But my observation, and I've had a lot of my colleagues have confirmed this with me, is that it is a very rare bird, and it's not just in the industry I'm in, it's in all industries. It's a very rare bird who has expertise in what I do, and what I do is all soft skills, and technical expertise. And the people the rare birds that have both of those skill sets are in very high demand. And they are the people that I've seen in every industry I've ever worked in who rise up through the ranks. So that would be my, I don't know how you all design your curriculum and if soft skills are even a part of it, but it's definitely a gap that I can see that needs to have some focus.
So I think it's a very exciting time to be a researcher. We have been gauging the marketplace literally for the last 23 years. We've seen substantial growth literally take shape across the entire state. And so what we try to focus on is the innovation cycle into the marketplace. It affects life sciences, it affects medical devices. We have a wonderful network as a researcher, and we're on the cusp, I think, of attracting people to the state, particularly this area, the Austin-San Antonio corridor right now. And President Trout, you're right. I mean, the vision right now is spot on. We are attracting a number of people that want to partner, that want to see what's on the shelf in terms of patents. We have a system that will help mentor and the ability for you to network. For example, you can go to the website, you can take a look at BioAustin, for example. And when they open their doors, you'll find 400 people under one roof coming in from all sorts of the life science arena. You can go to Biomed SA in San Antonio. Every time they open their doors, 400 to 500 people, and it's the who's who of the life science industry. But I just wouldn't keep your sights on the local area. You can go to Houston. There's an organization there called BioHouston. There is, in the Dallas-Fort Worth area, you have what's called BioNorth Texas. Every time they hold these events, El Paso, we just established a Bio El Paso Juarez. And El Paso is a hotbed of medical device innovation. And so today, on the commercialization process, the technology transfer process, it's a very, very exciting time because once you get past that academic threshold into the commercialization side, You're going to find Star Park. You're going to find Georgetown has an accelerator. You're going to find the city of San Marcos is very aggressive in their recruitment process. You're going to find you're going to find all types of opportunities, but it's going to take searching and it's going to take networking. But I think the timing is there. And so we couldn't be living in a more exciting time. I was in, we were in the fall, we did a 5-city tour, and we went into each of the major metropolitan areas. We held roundtable discussions. We invited the THBI members, we invited the leadership of the local healthcare community to come in and really talk about big ideas, because we were searching for what a secret 2 might look like. And let me tell you, the entrepreneurs today, the life science arena, our CEOs and their teams that they're assembling, they're not big teams. I mean, most of these companies, we have a 90% failure rate within the biotech arena alone. But our teams that are dedicated today to bringing their products to the marketplace, these are the modern day wildcatters. And I want to tell you, they are dedicated, and they'll go failure after failure, and yet there they are. And bringing their product to the marketplace. It's a fabulous time to be witnessing where we are, and I think we're in the right spot at the right time. Merck Health IT is a perfect example. J Labs, Johnson & Johnson moving into the Houston arena with their accelerator. The Army Futures Command. I mean, we are at a point right now to where I think it is very, very exciting.
It is an incredibly exciting time. And so my 2 cents on this, or maybe it's a whole nickel now with inflation, is don't forget about the long-term care system as you look around for opportunity. I'm a Gen Xer. I fully expect the baby boomers to completely break the current long-term care system. I don't believe for 2 seconds that the generation that invented Botox and Viagra is going to find nursing homes acceptable. It's not going to be a thing. So I just want some cereal and some cartoons, and I want it to work, and I want it to be real easy. But in all seriousness, if you look at our expenditures, an enormous amount of the money that we spend on our broken system is in the last 30 to 60 days of life in the hospital and in institutional care, and we still have institutional care. And technology can absolutely revolutionize institutional care, but it is going to be an incredibly hard lift, because those are those baked-in institutions, those physical plants that we've invested in. The nursing home's the biggest employer in my city. The hospital's the biggest employer in my city. All that change is going to be hard. But if you think of this from a demographic perspective, the boomers have just now started to enter their high utilization years, and the system is going to break. The question is, will we be ready with answers when it breaks? Will we already have the relationships in place when it breaks to say, Grandma doesn't have to go there, she can be home, and here are all the tools we're going to use to bring her home and keep her home. It's not about the tools. This is a question of willpower. This is a question of, do we want to be this good? Or do we want to think that that's someone else's problem until it's our own mother or our own grandmother? So everyone in this room is going to be touched by this long-term care phenomenon. Some of us sooner rather than later. Some of us are dealing with it right now in our own families. So for those of you that are systems thinkers and researchers and educators, don't forget, it's easy to not think about that system, because we focus so much on immediate primary care, and we should. It's not an either or. Don't let anybody tell you that it is. But please don't forget the long-term care system, because if we don't start to revolutionize that sector, we're all going to pay a really terrible price. And then I won't get cereal and I won't get cartoons. And so I need that. It's all about me. Generation X needs this to get fixed before we get on. So please. Oh, I make no apologies whatsoever. I want some Lucky Charms and some Super Friends. But I also don't want my mother to be in a nursing home and not get good health care. I don't want my grandparents to be in a nursing home. And I'm not picking on nursing homes as an inherently bad thing, but if we were going to build a long-term care system from scratch, would we build nursing homes the way we have them now? No one in this room would build that. So let's build something different. That's my challenge to you.
Yes, I just wanted to add one thing about an opportunity that we're pleased to have provided in the Central Texas area. It's more for students than it is for the researchers in the room. But we have a close partnership with Houston-Tillotson University in Austin. And last spring, we launched a capstone course with them where their College of Computer Science and their College of Biology have come together, and we provide mentorship from the Merck side, and these students take a set of data and they use technology to analyze the data, and specifically to analyze health disparities, and try to get at the root cause of some of the health disparities in their communities. And we were now embarking on our second semester having that collaboration with Houston-Tillotson. And it's already just in the 1 year that we've had this partnership, we just a few weeks ago sort of signed on the dotted line. We hired one of the students from HT who recently graduated. And another story we like to share is that one of the students who was in our course last year, he graduates in May, and he got 4 job offers for post-graduation, and he finally settled on accepting a position with PayPal. He's moving to California this summer, and he said without question, the thing that the interviewers wanted to talk to him about the most was the work that he did with Merck. So we're pleased to, we're proud to be here and want to keep working with partners to provide those kinds of opportunities.
Something to look up to.
That's right. Well, very good. I think if I can ask Susan to join us up on the stage to take a seat, and then I think, right, Walt and Melinda, the idea is to open it up for questions, Q&A. But I'm going to first ask Susan, since she's been taking notes. Do you have anything that you want to add to anything that any of the panelists spoke about?
You'll not be shocked to know yes.
Go ahead.
Thank you. I really enjoyed sitting, hearing what all of you had to say. So much of this goes back to a comment that I heard from a fellow who runs a very large healthcare system based in the Northwest Providence, which is now in 7 states. And Rod Hopkins, who's the CEO, going back about 4 years ago now, Providence is based in Seattle, and Rod thought that they needed to have a new website for the system. And so he asked the people within the system, could you build a new website? And they said, yeah, we can do that. It'll be ready in 18 months. And he said, I'm here in Seattle. I'm thinking I should get a second opinion. So they hired some people from Amazon who came over. And they did redo the website in 6 weeks. And then he hired some more people from Amazon, and then he hired some people from Microsoft. Eventually, there were about 150 people there who would come to the healthcare system from the tech companies. And he met with them one day, and he asked them, he said, what's the biggest difference to you working for the tech companies versus working in healthcare? And they said, you in healthcare spend no time whatsoever studying and understanding the needs of the consumer. And at the tech companies, we spend all of our time studying and analyzing and understanding the needs of the consumer. Which is why, when you buy something on Amazon, the algorithms will pop up the next 50 things that Amazon thinks that you should buy, right? It's because they've studied you and they've captured all of this data and they've built the systems that do that. Well, I was thinking about what all of you had to say, and really, what we haven't done in healthcare is really not, instead of paying lip service to the notion that we have a patient-centered system, we haven't really ever built a system around people and people in the way they're living their lives, and asked what it is that people want. Why does Tom not want to drive 50 miles and sit in a waiting room for 4 hours, right? Why, and maybe this issue of why do people not use telehealth enough? Well, first of all, are their providers using telehealth? Or are they having to switch to somebody they don't already know to use telehealth? Typically the answer is the latter. So, because you can't get your own provider to adopt telehealth, right? I don't ever now get an appointment with a doctor, a new doctor in my life who's not on ZocDoc, right? Which is the online service where you can basically make an appointment online. It's because why? It's because when it occurs to me to make an appointment, it's usually 9 o'clock at night, right? It's not at lunchtime when the busy work day. And so I think flowing through a lot of these comments was, so we kind of know this, we know we have to reconfigure the system around what people want, around data and information, using data and information and analytics in new and different ways. And so the opportunities to do that, as we heard, are just enormous. And I sit here thinking, okay, so let's get at it, because the opportunities are so great and the rewards, I think, so immense.
We have one follow-up. I think Senna wants to address one of the issues that Susan just raised, and that is...
And people talk about those concerns in their comments. If you know how to look into patient comments from surveys, from social media, from doctor review sites, people are constantly talking about those facts, social determinants of their health. Simple facts like they are living too far away from bus stops and they can't get to the bus stop on time to make it to the doctor's appointment on time. It is there in patients' comments. It's just not, unfortunately, even today, even with NeuroDX, it's not really on the forefront of every provider's thinking.
The response is that's too bad. Too bad for you. Get up earlier and take the bus faster.
So Walt's informing me we've got about 1 or 2 questions. Who's going to jump up? Amy Roundtree's hand went up first, I think.
Am I jumping up literally?
You're first, jumping up.
Standing up?
No, you don't have to. There's a mic coming to you.
Okay.
Hi, I'm Amy Roundtree. I'm Associate Dean of Research in the College of Liberal Arts, and I'm an enthusiast. I loved this panel. I thought it was enormously helpful. My question really revolves around medical humanities. And I wondered if each of the panelists could talk a bit about how ethics plays a role in the design process. You know, I heard one of you say that we have to catch up with technology, but humans are humans. And I wonder if there's any ethical considerations being thought through as we're designing these technologies that are exceeding us. The second issue, the question I had was really about diversity. I love that Newark is partnering with Houston Tillotson. I was the assistant director of the honors program, the very first generation of honors programs there, so I'm glad that you're there. But I do wonder in these technologies, as we innovate, if we're, how much of an explicit conversation are each of you having about people who might be left behind? Like folks with apraxia of speech who, when these amazing development, these AI technologies can track my voice, they can't understand these people. Or folks with disabilities who cannot use those technologies, people who cannot afford those technologies. Even deciding whether or not to use the last amount of minutes that they have on their 4-pay plan to call somebody for telemedicine. I'm just wondering how much in all of your realms these conversations are being had as we innovate. Oh, and then also whether or not you're using actual users when you talk about user experience, because what patients say in a survey versus whether or not they develop a survey is conditional on whether or not they're the kind of activated patient who will do that. Thanks.
Well, I'll just very quickly here, because we're running out of time. We work very closely with an organization called the Texas Coalition with Disabilities. And it's a coalition that probably has 100 organizations strong. They're very, very active at the Capitol. They're very active on any piece of legislation that is healthcare related in terms of making sure that that population is covered and included. One of the issues this year, and it's really amazing, and I think they're spot on, and it has to do with oral health. And if you look at a population that can't afford to go to the dentist or can't afford, doesn't have a dental plan, the point of care that they receive is in an emergency room that is going to be costly. It has to be covered. But can you imagine having to go to the emergency room because your dental problem has gotten to that point? And then what happens? They're prescribed opioids to kill the pain. So it's a problem that's feeding on itself. and they're just saying under Medicaid coverage, let's cover that dental, regular dental visit, and let's nip it in the bud and get very, very proactive. So there are some, that coalition, you go to their websites once again, they are at the forefront in terms of what needs to be done in terms of taking care of that population.
I'm going to get two very short answers, although those are great questions and they deserve probably an hour each. A lot of my work centers in the Medicaid program, and I used to work for the state Medicaid director. When you work with the Medicaid program, both ethics and issues around underserved populations, persons with disabilities are always at the forefront because of the program's design. So we have an e-health advisory committee at Texas Medicaid. We meet on Friday. We have a public meeting. Our chairman is an African-American physician who runs a big HIV clinic in Juarez and in El Paso. He's a practicing physician. He flies to Austin from El Paso to keep us honest because he's not a theoretical person. He's a provider who is working every day with underserved populations, and he is the absolute first to call anybody out who is not being considerate of the broader picture of how all this works. So Medicaid is an unusual creature in that we can kind of micromanage it through the legislature, but it's also a wonderful place because it is a place where you have to be thinking about pregnant women, people with disabilities, all these different categories that the program serves in a way that, quite frankly, in Silicon Valley, you might not be thinking about. And then the other thing I'll say really quickly is that Texas has its own Medical Records Privacy Act that is stronger and broader than HIPAA, that protects patient privacy in ways that HIPAA doesn't. So Texas has a really long, strong track record around patient privacy that frequently gets ignored. But from the perspective of our state legislature, the ethics of some of these things are something that we debate every 2 years. Tom and I are in these conversations every 2 years because there is a sensitivity. So Susan said, Fitbit has your data. The feds can't do anything about it, but the Texas Attorney General can. So the regulatory landscape is actually different here from a lot of other states who take privacy and ethics really seriously. But you also have to design that into whatever it is you're building up front, and people don't always think to do that because they're in a hurry to break it. Build it and then break it.
Yeah, one more.
Very quickly, and you're absolutely right that disparities exist not only in access to care, but also in the capability to express, experiences of care. Again, from our little corner of an innovative company based in Austin, Texas, what we are working to contribute to that problem is if you are, as a provider, able to see the full landscape, the whole universe of your patient's feedback, it is true that surveys aren't necessarily the medium where every patient either has the capability or interest in using to express, to vocalize their experiences. Usually elderly patients, believe it or not, use surveys. Gen Xers are more vocal on Facebook. Pregnant mothers, teenage pregnant mothers are very vocal on Twitter. So if you have the capability to capture all of this in these different platforms, you're hopefully making a dent, making a chip in this disparity, problem disparity of being able to vocalize and being heard. So that's all I wanted to say.
Well, very good. Will you all please join me in showing appreciation for
First, I want to thank all of you for coming and for participating in the Health Scholarship case. You know, a couple of years ago, President Trump and Provost were very smart in thinking about the future of our research mission at Texas State, and they realized that the future is here. To borrow a statement from your talk, the future has arrived at Texas State. Our health research mission is growing at an amazing pace. And surprisingly, or maybe not surprisingly, it is evenly distributed across the university. But at Texas State, that means it's also uphill. So we get together and we share our research, and we are so fortunate to have such a wonderful group of people to discuss these topics with us today. So I echo your thanks for each of you coming here today to join us, and I really appreciated everything you had to say. The great news is that this conversation can continue, because we have coming up our poster session, so all of the poster presenters will be available to talk to each other and to talk to our panelists and guests, and then the reception. So we hope that you will take part in that and continue this conversation so that you can talk with them. You know them now, but they don't know you. And I think a lot of the things that you talked about are being studied by really interesting ways and interesting approaches and interesting people at Texas. And so I hope that you'll have those conversations. As our Translational Health Research Initiative has continued to grow, I have become increasingly aware that there is one group of people at Texas State who keep the wheels on the bus for us in many ways. The Office of Research and Sponsored Projects, certainly your staff and others, but research coordinators in every single college do an amazing job at making it easier for faculty members to pursue funding for their research. And so, sorry, jumping. So this year, I'm so happy to say that we are able to recognize one of our research coordinators for excellence in contribution to health research, support of faculty, support of things happening in her own college, but also across the university, and also to help us to pursue funding for the research that we do. And so this year, we have the honor of recognizing the research coordinator from the College of Liberal Arts, Jessica Snyder. It's really great. Dr. Horton and everyone here, and enjoy yourself. Thank you.